Good afternoon. My name is Susan Kristiniak. I'm the Associate Director of Palliative Care for the University of Pennsylvania Health System. And I'd like to acknowledge our interprofessional team listed on the slide as I have the privilege to present our Innovators Project, our directives at Penn Medicine. The opportunity to create, share, and maintain your advance directive anywhere, anytime, and with anyone. So whether a chronic progressive illness or an unexpected catastrophic event, we have all personally or professionally experienced a situation that leaves someone able to discern what he or she would want for themselves. And with no advance directive and no conversations with loved ones available, it's difficult to be prepared for this moment. While research supports that 80% of Americans would prefer to die at home, only 20% get to fulfill that wish. And 60% of those remaining die in the hospital, with 1/3 of that group in critical care utilization in their final days. This type of reactionary care without direction is laden with distress and anxiety, and often results in care contrary to what the patient may have wanted. This care is also extremely high in cost. We know that in fact 20% of the Medicare expenditures are incurred in the last year of life, which nationally accounts for this very large number, $124 billion annually. This heavy burden borne both by the family and other stakeholders results from care that even care providers sometimes consider futile. Care of the patient may never have wanted to begin with. So we believe that by improving care preference capture, by improving information retrieval across transitions of care, and aligning care delivery efficiently, we would create opportunities to decrease this spending. Advanced care planning brings clarity and calm to those difficult decisions at end of life. We see that existing solutions currently fall short. Many patients never discuss their preferences. Less than 1/3 record their wishes, and those that do, only 25% of them are readily available in the electronic medical record, frequently with excuses as we've kept it in a safe place or never having had the conversation with their selected decision makers. So we understand why these solutions are failing. And because of these limitations to the process, it ultimately affects not just patients and families, but certainly all of our work. Through research, we've learned that starting the conversation about advanced care planning is socially uncomfortable and burdensome. Frequently hearing it's too soon when suddenly it's too late, and associating this discussion with imminent death, whether or not that's the case. And this caused us to ask, how can we increase opportunities and motivation to engage in this process? We learned that current forms lack context and meaning, leading us to the question, how can we accurately capture and translate patients' preferences? Complex scenarios of dialysis, resuscitation, artificial feeding are reduced in many forms to yes and no checkboxes. And we learned that accessibility and transferability are limited, which promotes the question, how can we make the document more dynamic, more accessible, so it's where it needs to be? The critical moment when both caregivers and families alike need to assure these preferences are carried out. OurDirectives.org is that platform. We created it to address these barriers. It's an online tool that guides users not only through the process of creating their advance directives, but adds the ability to share this document with care providers and their decision makers. Our directives allows us to engage patients in various settings. That included the clinic, the hospital, and home, and monitoring their progress through various feedback mechanisms in our testing. Ultimately, we can distribute patients' completed advance directives so they're readily available when and where they're needed most, assuring that we're providing the right care in the right place and at the right time. So in the past 90 days, we've done 9 experiments in various contexts, all for less than $100. User testing has resulted in insights that enable iteration of the platform as well as a larger Our Directives ecosystem. Our testing taught us how to effectively reach users. We implemented 6 unique advertisements over 4 days that resulted in 361 individual website clicks. Our findings revealed that initiation rates were in fact twice as high when the emphasis of messaging was placed on one's family, such as help them make choices you would want. We integrated a brochure with our social work colleagues in multiple settings at the Hospital of the University of Pennsylvania, which taught us that providing an actionable resource can be impactful and capture users who otherwise wouldn't even know where to begin the experience. Our findings reveal that hospitalized patients, in fact, might be overwhelmed in that setting with these conversations, and this presents another opportunity for us to explore other methods of engagement. Through user testing, a common barrier that we faced or we were seeing is that completion was identified in the questions regarding life support. Our online platform had integrated feedback mechanisms such as skip for now, so it wouldn't hold up the process of completion and following through in the whole document, and a live chat shown in the text exchange where this particular person asked how dialysis would affect their daily life. So we can actually capture where people are getting stuck, and then how to best support this document's completion. Using these findings from the past 90 days, we've identified the following areas. Enhance current workflow to provide an actionable resource. Leverage social influence to increase a sense of urgency, but also understand the value of the completed document. And provide more clarity on the context of the information, and capture this in a situation that would be much more available to all. So looking forward, we have started a pilot at the Abramson Cancer Center at Pennsylvania Hospital just this week, where we're testing the integration into clinical workflow in their infusion center. We will test further hypotheses around completion and value, build allowances for multi-user scenarios, and ultimately, we will work towards integration into Penn chart. So these documents would automatically insert themselves into our electronic medical record when completed. So in closing, I'd like to share with you a note that was received by one of our team that truly reflects the social impact and the emotional impact of a person who had completed their advance directive. And in quotes, it was with great sadness I inform you that my husband passed away. Having a living will prepared us to make difficult decisions based on his wishes during his last days. Thank you for your help and its preparation.